So, third video. I am going to lose count of this fairly soon. Um, Third video. We're going to be looking at the subjective examinations, and we're going to start with pain. This is obviously the most important symptom and obviously the most frequently given symptom for any of your patients. Unless you're doing neurological therapy, respiratory therapy, or some other form of therapy, in orthopedics and manual therapy, pain is the number one symptom. So this is what we're going to be talking about. This will probably take up an entire video, and then we'll bring in the other symptoms later on, but we'll see how we do. Um, Typically, pain is split into somatic pain, non-somatic pain, um, where somatic means bodily pain. Non-somatic pain would be things like phantom limb pain, psychogenic pain, and so on. We're going to change it a little bit because I think that we can make the terms a little bit more useful for us. For us now, so somatic pain means locomotor system pain, and visceral pain will be pain coming from the viscera, not from the visceral linings, because that ends up being somatic pain, but from the viscera itself. And then neuropathic pain is actually coming from the nerves and neurological system. So we've got three types of pain we're going to be speaking about, and each one has a different quality to the other. So it's a useful way of splitting this up. Somatic pain, as we've defined it, as I say, comes from the locomotor system. So this would be pretty much anything to do with movement, other than the nerves themselves and the neurological system itself. Muscles, joints, tendons, ligaments, blood vessels, anything pretty much that has nociceptors in it. This has a particular type of pain that differentiates it from the others, and probably it's best to leave this one to last, simply because mostly it's an exclusion of the other types of pain, and there's too many different types of somatic pain to use as a definition for it. So we'll look at visceral pain first. The pain from viscera seems to be mitigated by the fact that the viscera don't have very many nociceptors, while the linings of the viscera do. Also, the nerves coming from the viscera are small and often non-myelinated. So this gives you a particular type of pain. It tends to be deep, dull, diffuse type of pain that is never sharp. It just gets sorer and sorer and sorer. It's a heavy pain. It's difficult to isolate as to where it is often. It'll often start off bilateral, regardless of the unilateralness of the organ. It'll often start off bilateral and then often comes down and localizes over the organ. It can also refer well away from the gut, and these are called head zones. And if you look on Wikipedia, you'll get some information on head zones. I'll just put head zones into Google and you'll get some information on it. But these are similar to the way somatic tissues refer pain. But it is more dull and diffuse. It's quite a distinct pain. The linings of the viscera, though, are heavily innervated and also myelinated, and this can give you very much a somatic type of pain, quite a severe pain. And the quality of the pain really doesn't help you determine whether or not it's coming from a somatic tissue or a visceral tissue. But that's visceral pain. Neuropathic pain comes from damaged nerves and damaged neurological structures. There are three types of neuropathic pain if we include paresthesia as a pain. And given the vagueness of the definition of pain as an unpleasant sensation with emotional overtones, we certainly can include that as a pain. So we have paresthesia as one symptom coming from the neurological system. We have lancinating pain, a sharp electric pain that zings down the limb or zings around the ribs if it's coming from the nerve root, which it usually does. It's unusual for the nerve root to produce any other type of neuropathic pain. And then there is Corsalgic pain. and this is mostly, it's interesting, but this is mostly confined to the peripheral nerves in normal um, everyday manual therapy practice. It's almost entirely from the visceral nerves, in which case it will have visceral nerves, sorry, it's almost entirely from the peripheral nerves and will have a peripheral distribution. And it is causalgic, so it's a hot, dry, itchy pain, the intensity of which can be extreme to the point where the patient wants to cut their arm off. Very, very hot and burning, or something that feels like somebody's dragging twigs over their limb. Itchy, scratchy sort of pain. This can also come from the central system, and one example of this is Thalamic Syndrome, where you get a tumour in the thalamus, and you'll get a total body Corsage, and patients will often describe this as being roasted over an open fire. Good luck with that one. The thing is that the neurological tissues cannot produce any pain other than those, except possibly for the spinothalamic, which can give you a somatic pain, but it's very rare. But in general, the neurological system, and particularly the peripheral nerve and the radicular nerve, will give you this radicular pain, this electric shock type pain, or Causalgia in the case of peripheral nerves. Somatic pain comes from locomotor structures. For us, probably the most common one comes from biomechanical dysfunctions where the nociceptors are stimulated, but also from the dura. If we're looking at disc herniation, stenosis, it's ischemia from central stenosis and lateral stenosis and so on. This will be an ache or a very, very sharp pain. A stabbing pain sometimes. The quality of this pain is described differently by different cultures. If you hear an Englishman talking about quality of pain, those descriptors are probably going to be different from an American talking about them. But this is a way you can define somatic pain, is that it isn't visceral and it's not neuropathic. So there are your types of pain. After this, you've got to talk about its behaviour, its intensity, whether it's progressing or not progressing, what aggravates it, what makes it feel better, and so on, episodicity and so on. So all of that will come into it, but the actual descriptions of the pain will fall into one of those three groups. And those three groups will give you an idea of basically what you should be doing with the pain. Visceral pain should be referred out. There's no reason at all for you to do anything other than identify what it is and fire it out. The heart problem, on the other hand, problems with the heart, it's muscle. So this isn't viscera the way we think of viscera. This is muscle, and this can give you very sharp locomotor type pains. Also, the pericardium is innervated with lots of nociceptors, and that will give you somatic pain. So visceral pain isn't a major factor with heart disease, but with viscera, it is. This is also mixed up though, because you get something like renal calculi where you get stones in the kidney, and they seem to cause kidney pain often by tearing into the tubules and the blood vessels supplying those tubules. So you get again a somatic type of pain from this. So it's not cut and dried, it's not black and white with the visceral pain. Neuropathic pain actually is. It's quite distinct from somatic pain, it's distinct from visceral pain, and you know you have a neurological tissue that's producing pain. So this is something you want to be aware of. Essentially, if you're getting neuropathic pain with a disc herniation, for example, it means the nerve is damaged. So the prognosis is nowhere near as good as if you weren't having neuropathic pain. But this is a definite cut-off point. If you've got neuropathic pain, you have a radiculopathy. Assuming it is a radiculopathy, it's going down the right distribution. But a lot of radiculopathies will not have neuropathic pain, because although the nerve is being compressed, it seems not to be producing this neuropathic pain without damage. And it's not the nociceptor, it doesn't seem to be nociceptors that causes this. It's basically an ectopic firing of the nerve. The nerve, which is damaged, gets stretched, compressed, moved, twisted, and it fires. It's just fires, and that's what it fires. It's zinging electric type pain. So ideally we'll be dealing with somatic pain. Sometimes that'll be, we'll have neuropathic pain, but never visceral pain. You don't want anything to do with visceral pains. So I hope this helps, and I'll see you next time. Bye bye.